Gentlemen, welcome to the inauguration of the 133rd Anniversary International Virtual Medical Congress of the Sri Lanka Medical Association. As the leading medical association in Sri Lanka, the SLMA has always been committed to continuous professional development. So even amidst a global pandemic that is challenging every aspect of our lives, the SLMA has taken up this daring task to have its annual academic sessions, even under such trying circumstances. So we all have been compelled to adapt to a new normal way of life, and the results are evident today. This year's annual academic sessions of the SLMA will be conducted as a virtual conference, which will be broadcasted live from the Vijayarama House in Colombo. And all the precautionary measures that will be adhered to are in keeping with the guidelines issued by the health authorities in order to prevent the spread of COVID-19. So the Congress will actually bring together many local and international resource persons and experts onto a single virtual platform to bring to you a stimulating academic program, which we hope that you all would enjoy. And ladies and gentlemen, this inauguration ceremony will commence with the ceremonial procession. And traditionally, this ceremonial procession consists of the Council of the Sri Lanka Medical Association, along with the past presidents. But however, this year, in order to adhere to the social distancing norms, the Council of the Sri Lanka Medical Association, the members of the Council, are already seated here in the audience. So the procession will consist of the president-elect, the past president, the guest of honor, and the orator of this evening. And this ceremonial procession will be commencing now, and I kindly request the audience to stand for the ceremonial procession. Thank you. Please remain standing for the national anthem.
Surrender
seated. So, ladies and gentlemen, as tradition calls, we will now proceed to lighting of the oil lamp, which symbolizes the light of learning. However, this year we have had to deviate a little from tradition in order to adapt to the new normal way of life. So instead of using a single candle, which is shared among all the dignitaries, they will be provided with individual candles. And we kindly request all our dignitaries to maintain social distancing and approach the lamp individually to light it. So it is with great pleasure that I now invite our guest of honor, Major General Dr. Sanjeeva Munasinghe, Professor Indika Karunatilaka, the President of the Sri Lanka Medical Association, the President-elect of SLMA, Dr. Padma Gunaratna, to light this lamp of learning. Thank you. Before we proceed with the rest of the day's program, I would like to invite the following dignitaries to be seated at the head table. Major General Dr. Sanjeeva Munasinghe, the Secretary of the Ministry of Health, Sri Lanka, Professor Indika Karunatilaka, the President of the Sri Lanka Medical Association, the Orator of the SLMA Inauguration 2020, Professor Sachit Mettananda, and Dr. Sumitra Tissera, the Secretary of the Sri Lanka Medical Association. Thank you, sir. So, ladies and gentlemen, it is with great pleasure that I now invite Professor Indika Karunatilaka to officially welcome the gathering.
Very good evening to all of you, and greetings from Sri Lanka Medical Association. Major General Sanjeeva Munasinghe, Secretary to Ministry of Health, and our guest of honor this evening, Dr. Dujipa Samarasekara, Director, Center for Medical Education, National University of Singapore, our guest of honor, patrons, past presidents, council members, and members of Sri Lanka Medical Association, resource persons of the 133rd Anniversary International Congress, and all the participants joining us in person as well as online. It's a great pleasure and privilege for me to welcome all of you for the inauguration of the 133rd Anniversary International Medical Congress of the Sri Lanka Medical Association. In April 2005, SLMA News, the newsletter of Sri Lanka Medical Association, carried the editor's note. SLMA sessions totally virtual, a dream or reality. That prediction I made 15 years ago as then editor of SLMA, has now become a reality. The 133rd Anniversary International Medical Congress of the Sri Lanka Medical Association will be held as a virtual online conference from today till 26th of July and webcast worldwide. And the SLMA conference returned to the historic Vijayarama House after 20 years. Established in 1887, SLMA is the oldest professional medical association in Asia and Australasia. It has contributed immensely towards the betterment of health of the nation over the years. During this COVID-19 pandemic, SLMA has helped to contain the spread of COVID-19 in Sri Lanka by playing a pivotal role, advocacy role, and creating awareness among public and the stakeholders. COVID-19 has inflicted unexpected and unprecedented degree of uncertainty worldwide. During this era of uncertainty, SLMA took a bold decision to go ahead with the Congress, considering our responsibility towards maintaining CPD and CME. This Congress will be a rare opportunity for medical professionals, allied health professionals, and students in Sri Lanka to present their research findings in an international conference during year 2020. The conference is aptly themed Professional Development for Quality Enhancement of Healthcare Beyond the COVID-19 Pandemic. Pre-conference workshops, keynote address, symposia, and guest lectures are planned, considering the need to adapt to the new normal. The Congress will give us an opportunity to listen to, engage, and learn from the experts and practitioners on best practices. The challenges facing when organizing this conference was immense, and my heartfelt gratitude goes to everyone who contributed towards making this Congress a success, including the guests of honor, the resource persons, steering committee, SLMA office staff, sponsors, and very especially all the participants. With over 400 registered participants and the expertise provided by local and international resource persons, this is going to be a landmark global event. Once again, I welcome all of you for the 133rd Anniversary International Medical Congress of SLMA, and have a great time. Thank you.
Thank you, sir. And it is indeed quite serendipitous that you have led the efforts to make your own predictions made 15 years ago become a reality today. So, sir, let me call upon you once again to introduce our guest of honor, Major General Sanjeev Munasinghe.
Major General Sanjeev Heman Munasinghe, a product of Tissa Central College, Kalutara, and obtained his MBBS degree from University of Ruhuna in 1984. He then joined Sri Lanka Army Medical Corps in 1986. He obtained MD Radiology in 1993. Subsequent to this, he received his fellowship in Neuroradiology and Interventional Radiology in the University of Sydney, Australia, and fellowship in Neurointerventional Radiology from Oxford University in 1999, and fellowship in Advanced CT from Maryland University, USA in 2000. Dr. Sanjeev Munasinghe has served as a field medical officer in almost all military operations, from Operation Vadamarachi in 1987 to the last humanitarian operation ended in 2009. While serving as a consultant radiologist at the Army Hospital Colombo since 1995. He was the commanding officer at the Military Hospital Colombo from 1996 to 2000 and director Army Medical Services from 2000 to 2009. He was the medical advisor to the Commander of Army from 2009. He has served as the president of Sri Lanka College of Radiologists and was the president of Sri Lanka College of Military Medicine, and also served as the executive committee member of Asian Musculoskeletal Society. He has several international accolades, and member of several international organizations in radiology. He has carried out over 100 presentations in both local and international conferences. Major General Dr. Sanjeev Monasinghe has delivered several orations, namely the second SNB Talwate oration in 2013, Professor Charles Robb oration in 2020, Uniformed Services University of Health Services, and Walter Reed National Military Medical Center, Maryland, USA. Dr. Monasinghe has several publications and several awards among his many accolades, including the best paper for the 114th anniversary medical sessions of SLMA in 2011. In recognition of his bravery in the battlefield, Major General Monasinghe was awarded gallantry medals, Ranasura Padakkama RSV 3 times, and Ranavikram Padakkama RWV once again for the distinguished services for the military. He was decorated with the Vishishta Seva Vibhushana VSP and Uttama Seva Padakkama USP. His contribution to medical and military arenas is indeed commendable and noteworthy. Ladies and gentlemen, we cannot think of more appropriate person than Major General Sanjeev Hemant Monasinghe to grace this occasion of the inauguration of 133rd International Anniversary Medical Congress of Sri Lanka Medical Association. Over to you, Dr. Monasinghe.
Thank you, Professor Indika, for that kind words. His Excellency Gotabaya Rajapaksa, the President of the Democratic Socialist Republic of Sri Lanka, Dr. Dujiba Sambrasekara, Chair, Faculty of Teaching Excellence Committee, School of Medicine, National University of Singapore, Professor Indika Karunatilaka, President, Sri Lanka Medical Association, Council members of Sri Lanka Medical Association, distinguished guests joining from Sri Lanka and from all around the world online, ladies and gentlemen, good evening. It is indeed a great pleasure to speak few words to this august gathering at the 133rd International Medical Congress of Sri Lanka Medical Association. So far, year 2020 has been an eventful and difficult one for the health sector. At the inception of the year, Corona took the world by storm. Countries all over the world, one by one, fell prey to this novel virus infection. Sri Lanka too became a victim in early March, causing much havoc and hardship to all human beings. We identify Sri Lanka Medical Association as one of the foremost professional and academic organizations playing a pivotal role in the management of this disease in Sri Lanka. Advocacy, education, guidance, formulation of guidelines were some of the main activities carried out by members of Sri Lanka Medical Association under the able leadership of Professor Indika Karunatilaka. It is acknowledged that the SLMA members have worked beyond their usual role to combat this pandemic. As such, the theme of this year's Congress, Professional Development for Quality Enhancement of Healthcare Beyond COVID-19 Pandemic, is one that is apt and current, and I congratulate Sri Lanka Medical Association on the selection of this appropriate theme. This topic needs full attention and consideration, given the current circumstances of the world, since government, health sector, and the armed forces are in action to look beyond the identification and prevent further spread of the coronavirus and in quarantine process. Being one of the oldest and largest medical professional bodies in Asia. The Sri Lanka Medical Association has membership of medical officers of different grades and different specialties, thus making a common platform for Union of Medical Professionals. The annual International Medical Congress brings medical professionals of various fields together and create a pleasant atmosphere for exchange of information, knowledge, and an opportunity to present new researches and concepts. The range of topics covered in this Congress and the list of eminent local and international speakers from health as well as non-health sector further support this. The Sri Lanka Medical Association has gone further to create a web-based Congress, ensuring its availability to many Sri Lankans and international medical professionals while adhering to preventive measures. This is indeed commendable. On the special day, I would like to acclaim Sri Lanka Medical Association on their continuous service to the nation. Their collaboration with Ministry of Health and involvement in health policy development and guidelines has made a marked contribution to the health sector. I sincerely hope this collaboration between the SLMA and Ministry of Health will continue in future towards a great service to the Sri Lanka. While congratulating Sri Lanka Medical Association on planning of such a magnificent event, I wish all the participants a very successful 133rd International Medical Congress. Thank you.
Thank you, sir. We are truly honored by your presence here with us today. So, ladies and gentlemen, I cordially invite Professor Indika Karunatilaka again to introduce our next guest of honor, Dr. Dudeepa Samarasinghe, who will be joining us from Singapore. Over to you, sir.
It's indeed a great pleasure to introduce my colleague and friend, today's guest of honor, Dr. Dudeepa Samarasinghe. Dudeepa graduated from University of Colombo, Sri Lanka with MBBS honors in 1995. And after training as a pathologist and a physician, then decided to move into medical education and with further training in Netherlands. Now, currently, he is a director of the Center for Medical Education at the National University of Singapore and a leading figure in international arena of medical education. He holds several prestigious positions in medical education organizations worldwide, that including Association of Medical Education in Europe, World Federation of Medical Education, Asia Pacific Academic Network in Medical Education. He is the present president of the College of Clinical Education at the National University and the Academy of Medicine in Singapore, and the president of the Western Pacific Association of Medical Education. Dudeepa serves in editorial boards in many prestigious journals in medical education, including the Annals of Academic Medicine Singapore, Southeast Asian Journal of Medical Education, Korean Journal of Medical Education, BLD Medical Journal, Perspectives in Medical Journal, and AMI Online. Dudeepa is an honorary professor and visiting faculty at Sochi University, Taiwan, Semeri State Medical University, Kazakhstan, University of Maastricht, Netherlands. He is a fellow of Academy of Medical Educators in the UK, Medical Educators Europe, Academy of Medicine Singapore, Academy of Medicine Malaysia, and a fellow of Royal College of Physicians. On a personal note, it was 20 years ago that three of us, myself, now Professor Gominda Pannamperuma, and Dudeepa joined the then unknown field of medical education. And since then, he has gone so far and done so much for the Sri Lanka for the field of medicine and medical education. it's my great pleasure to invite Dr. Dujip Samarasekara, who will be joining us from Singapore.
For that kind introduction. Good evening, everybody. President, Sri Lanka Medical Association, Professor Indika Karunatilaka, Major General, Dr. Sanjeeva Munasinghe, Secretary, Ministry of Health, Sri Lanka, the Sri Lanka Medical Council, invited guests, speakers, ladies and gentlemen. It gives me great pleasure to share a few words with you today. I feel honored and privileged to be invited for the 133rd Anniversary Congress as a guest of honor. I will be short in my message and try to highlight few important achievements by SLMA. It is also a personal milestone for me because this month, 25 years ago, I joined this great organization as a life member right after graduating from the Colombo Medical Faculty. Sri Lanka Medical Association is one of the oldest medical professional organizations in the world. It has undoubtedly contributed to the advancement of the profession, as well as helped in building a community of like-minded practitioners in Sri Lanka, regionally, and internationally. I'm delighted to see how SLMA has grown over the recent years. Due to the visionary leadership of Professor Karunatilaka and the Council, SLMA has moved beyond the traditional boundaries to uncharted areas successfully. It is heartening to note how SLMA took a leadership role in the management of the current health crisis caused by COVID-19 virus. SLMA's impartial interventions, guiding and advising based on best evidence practices to both the authorities and the general public is an example to other organizations and expert committees. The use of technology in an appropriate way to benefit the membership and the community is another excellent example. These sessions would not have been a reality if not for SLMA taking this bold step to venture into the online platform in such a short period of time. Another very commendable new approach is the engagement of relevant stakeholders beyond medicine in the discourse to find common solutions to health and disease. This is an excellent strategy in our efforts to involve interprofessional and multi-professional experts or groups to improve the health and well-being of our society. A step in the right direction in today's context, where the issues and challenges we face are complex and multidimensional. These rapid changes over a short period of time during a difficult time are not easy. May I quote Bernard Shaw, "Progress is impossible without change, and those who cannot change their minds cannot change anything." I would again like to congratulate the able leadership of SLMA led by Professor Indika Karunatilaka, the Council, and the committee for taking all these progressive steps and organizing the 133rd Anniversary Congress during a challenging time very successfully. May I wish you all the very best and successful SLMA 2020 sessions. Thank you very much.
Thank you, sir, and we are truly grateful for your presence here with us at this landmark event today. And ladies and gentlemen, continuous professional development and continuous medical education have become vital elements in this fast evolving and fast growing field of medicine. So over the years, the SLMA has played a pivotal role in providing CPD opportunities for doctors in Sri Lanka, as well as other allied health and other health professionals in the country. So the SLMA has conducted many clinical and regional meetings as well as other CPD activities throughout the year before this as well. So in keeping with that, today we'll be launching the SLMA CPD portal and health education material. So it is with great pleasure that I invite Professor Indika Karunatilaka and our guest of honor, Major General Sanjeeva Munasinghe, to launch the SLMA CPD portal.
Thank you very much. And if I may speak few words, the CPD is, as mentioned, private area for SLMA. It has been during last 20 years. Actually, it was Sri Lanka Medical Association who introduced the concept of CPD to Sri Lanka. That was during the presidency of Dr. Sunil Senaviratne Appa. Even before that, the SLMA sessions, the traditional SLMA sessions, and the activities of SLMA was actually CME and CPD. So in that sense, SLMA has been the undisputed leader in CPD and CME in Sri Lanka. And this year, one of our priority areas was CPD. The theme for this year was quality enhancement of healthcare through CPD, continuous professional development. And that was more so because of my involvement as a medical educationist. And we saw one area, that is technology is the way to take the CPD forward. So because of that reason, SLMA, we have developed a CPD portal, because one argument was we cannot implement CPD without material. And at the moment, there should be opportunity even for the doctors who are working in the periphery to access CPD and update their knowledge, because that is a pressing need. And this year we have done a lot of work through technology. And in a way, the challenge of COVID-19 was, in that sense, was a blessing in disguise, because we were compelled to go into technology, and with that, we were able to reach very large audience. Yesterday, there was the last pre-conference workshop of this congress, and there were several participants joining from all areas in the country. And for this conference also, there are several international resource persons and participants. So CPD should be the way forward. So with that in mind, SLMA has come out with this CPD platform, which basically covers most of the areas in the module platform in the module format. So basically, this provides a platter of content for the medical officers and doctors, and they can select the areas that they can want to go through. And then through a national common pathway, common platform, where we need the support of the Ministry of Health. If the Ministry of Health can provide us a framework for CPD, where the doctors can make use of any platform like this, because Ministry also working on several other CPD projects, then these would be the resources for CPD. So that was the whole idea. And this platform will provide a buffet of content for different areas, which is completed now. And this includes mobile-based self-learning app also, which is developed by the SLMA experts, which can be used in the mobile platform also. So this was a lot of work, and SLMA is indeed proud and privileged to launch this CPD platform. And similarly, during this time, during the COVID-19, we have done a lot of work with other stakeholders, including the ministry and also different organizations. And in collaboration with the IME, that is the medical education network, IT-based medical education network in Sri Lanka, led by one of our own colleagues, and Dr. Dinila Begunawardena, we have developed a series of videos, health education videos that was aiming at health education regarding prevention of COVID-19. I would like to invite Dr. Dinila also on upstage to hand over the CD containing the educational videos to Major General Munasinghe, so that the Ministry of Health also could be used in the resources. Over to you.
Thank you. And thank you, Professor Indika, for spearheading and guiding the efforts to make the SLMA CPD portal come into fruition. So, ladies and gentlemen, with that, we have nearly come to the end of the formalities of this inauguration ceremony. So, I would like to invite Dr. Sumitra Thisera, the Honorary Secretary of the Sri Lanka Medical Association, to propose the vote of thanks.
A guest of honor, President of the Sri Lanka Medical Association, Chairman and members of the Board of Trustees of SLMA, past presidents, members of the Council, members of the SLMA orator for tonight, invited guests, and all guests participating online, and ladies and gentlemen. Good evening to all of you. As the Secretary of the SLMA, it is indeed an honor and a privilege to propose this vote of thanks. First and foremost, I would like to thank our guest of honor, Dr. Sanjeeva Munasinghe, Secretary to the Ministry of Health and Indigenous Medical Services, for accepting our invitation and gracing this occasion despite his busy schedule. I also like to thank Dr. Dujipa Samarasekara, Director, Center for Medical Education, NUS University, Singapore, for joining us via Zoom. I thank the invited guests, including officials of the Ministry of Health, WHO, UNFPA, and World Bank. Your presence here today is indeed a much valued gesture of encouragement to the SLMA. My sincere thanks goes to all our council members who are physically present today, and to the members of the Board of Trustees of the SLMA, the past presidents of the SLMA, and the members of the SLMA Council connected with us remotely via an electronic portal. The main academic program of the Congress, commencing tomorrow and held during the weekend, is delivered through one keynote address, 2 plenaries, 6 guest lectures, 8 symposia, and 7 public education sessions. Already there were 8 pre-Congress sessions during the past month. There will be 3 orations delivered during the Congress. I wish to thank all overseas and local resource persons, orators, chairpersons of the Congress session, and chairpersons and judges of the oral and poster presentation for their contribution. We truly value your continuous support. The Doctors' Concert, which showcases the artistic talents of our members and their families, will take place on 26th Sunday from 7 p.m. onwards at the new auditorium, Postgraduate Institute of Medicine, Colombo 8. I wish to take this opportunity to thank all the performers and Mr. Ray Gomez and the band who will entertain us on that day. I would also like to make a special mention about Dr. Sankarandani Kumar and Cristo Fernando for their enthusiasm, devotion to the task in making this year's concert a success. An event of this magnitude and caliber in the current Sri Lankan context cannot be organized without the collective effort of many individuals and organizations. The SLMA deeply appreciates the contribution of the Ministry of Health, our partners, and our sponsors. Who kept faith with the SLMA and were generous enough to support us, our conference, even during these trying times. Thank you very much for your support towards continuous professional development of the medical profession. Professor Indika Karunatilaka, President SLMA, needs a special mention for leading the SLMA through the adversity of a pandemic and organizing one of the 4 most web-based conferences in Sri Lanka. The SLMA Council is appreciated with much gratitude for the trust they placed on the President and organizing committee to make this Congress a success, a task they undertook over a very short period of time after the release of the lockdown in May. I would also like to extend my appreciation to all the members of the Congress Organizing Committee, Professors Indi Karunatilaka, Manoj Veerasinghe, Dr. Padma Gunaratna, B.J.C. Pereira, Sarath Gamini De Silva, Kalyani Guruge, Shiranthi Liyanage, Ashwini Diabru, Nimani Boralassa, Sankarandini Kumar, Sajit Edirisinghe, and Pamud Amarakon, editors of the proceedings book, Doctors Chiranthi Liyanage and Ashwini Diabru, for all the enthusiasm, time and effort you put in to make this virtual Congress a reality. Dr. Pamud Amarakon, our IT expert, needs to be thanked separately for all the work put in by him, even with his exam, to secure the smooth running of the IT platform. Co-editors of the Ceylon Medical Journal, Professors S. Patmeswaran and Senaka Rajapaksha, and the editorial board are thanked for reviewing the many abstracts well within the deadline. My heartfelt appreciation goes to the staff of the SLMA, Ms. Jairani Nirmala Nadira and Mr. D.S. Pereira Samaratna, Justin, Mr. Salmi and Raja, Dr. Tiline Godage, our pre-intern medical officer, and Ms. Karsha Chandrasena, who worked tirelessly for the last 2 months in supporting us in every way to make this event a success. I also like to thank Dr. Kaushi Attanayaka, Dr. Rizka, Dr. Upeksha, Dr. Sashika, and the first-year medical students of Sri Jayawardhanapura Medical Faculty who will be supporting us during the Congress. A special thank you is extended to Dr. Jagat Wickramasinghe and Dr. Nilanka Munasinghe for the musical performance and Dr. Chiranthi Liyanage for comparing today's event. I also would like to thank IME for the production of this event. No event would be colorful enough, even in the new normal, without some physical presence. I would like to thank all of you who are present here with us today. I wish all the resource persons and the registrants a memorable and an enjoyable virtual conference, both academically and socially. Thank you. Have a pleasant evening.
Thank you, Madam. So, ladies and gentlemen, that brings us to the highlight of this evening, the SLMA Oration 2020. So I kindly request our dignitaries at the head table to be seated along with the audience for the SLMA Oration. And ladies and gentlemen, this year's orator is Professor Sachit Methananda, Professor and Head of the Department of Pediatrics, Faculty of Medicine, University of Kelaniya. So I cordially invite Professor Indika Karunatilaka to introduce and invite the orator. Over to you, sir.
Professor Sachit Methananda is at present the Professor in Pediatrics at the Faculty of Medicine, University of Kelaniya, and Head of the Department. He is attached as a consultant pediatrician to the Colombo North Teaching Hospital, Ragama. Having obtained his MBBS degree from the University of Colombo with many accolades, he went on to do his postgraduate studies, firstly the Diploma in Child Health in 2007, at which he obtained the prestigious SLCP gold medal, and following this MD in Pediatrics from the University of Colombo. He then obtained a DPhil from Oxford in 2015 and FRCP from Edinburgh in 2020. Professor Methananda has also served numerous awards, including the President's Award for Scientific Publications in 2011, 2015, and 2016, the 10 Outstanding Young Persons in Sri Lanka Award 2016 in Medical Research, and Commonwealth Scholarship Award in 2012. He has also received several awards during the sessions held by the Sri Lanka Medical Association and the annual Congress of the Sri Lanka College of Pediatricians. His research publications are many in number, including 12 H-index publications, and he has additionally authored 4 book chapters and over 60 peer-reviewed publications. In addition to his numerous accomplishments, he also served in both National Thalassemia Council of Sri Lanka and National Health Research Council of Sri Lanka, and serves as an editorial board member of the Ceylon Medical Journal and Sri Lanka Journal of Child Health, And again, on a personal note, Sajith has been a student of mine, few years junior at the Colombo Medical School, and later at the same, the Old Boys Association, the same school. So it's a great pleasure and privilege to present this year's SLMA orator, Professor Sajith Mettananda, and award the Orator's Medal to him.
Good evening. Major General Dr. Sanjeev Munasinghe, Secretary to the Ministry of Health, Dr. Dujiba Samarsekara, the guest of honor of today's event, Professor Indika Karunathilaka, the President, and the other office bearers of the Sri Lanka Medical Association, council members of the Sri Lanka Medical Association, distinguished invitees joining on site today, as well as online, ladies and gentlemen. At the outset, let me thank the President and the Council of the Sri Lanka Medical Association for awarding me the honor of delivering SLMA Oration 2020. I consider it as a great honor to deliver the most prestigious oration of the association. During the next 30 to 40 minutes, I intend to present our ongoing work on improving standards of care for children with thalassemia in Sri Lanka. Ladies and gentlemen, thalassemia is one of the most common genetic disorders in the world, which is particularly common in the tropical regions, including South Asia. Worldwide, approximately 70,000 children are born with various forms of thalassemia each year. Beta thalassemia, which has a carrier frequency of 2.8%, is the commonest genetic disease in Sri Lanka. Approximately 1,800 patients with beta thalassemia are treated in 26 different centers in Sri Lanka at present. However, over 2/3 of them are managed in 3 largest thalassemia centers located in Kurunegala, Anuradhapura, and Ragama teaching hospitals. Of the various subtypes of thalassemia, beta thalassemia major and hemoglobin E or HBE beta thalassemia are the commonest subtypes in Sri Lanka. A recent island-wide survey reported that 70% of patients with thalassemia in the country has beta thalassemia major, whereas 20% has HBE beta thalassemia. The remainder has rare forms of thalassemia. Beta thalassemia is caused by genetic mutations in the human beta globin gene, which is located on chromosome 11. These mutations decrease the production of beta globin chains by interfering various stages of gene expression, and they demonstrate autosomal recessive inheritance pattern. Beta thalassemia major, the severe most form of beta thalassemia, is caused by inheritance of 2 beta thalassemia mutations in the homozygous state. In contrast, the molecular basis of HBE beta thalassemia is complex and complicated. In HBE beta thalassemia, one allele of the human beta globin gene carries a beta thalassemia mutation, whereas the other allele carries beta E mutation. Beta E mutation is a mutation that results in structurally abnormal hemoglobin E. Hemoglobin E is a functional hemoglobin which is synthesized at reduced rates. Depending on the level of HBE produced, the severity of HBE beta thalassemia varies from a mild asymptomatic disease to a severe disease which is transfusion dependent. All severe forms of beta thalassemia result in profound anemia. These patients present during first year of life with pallor, hepatomegaly, and bony changes. They require monthly blood transfusions and are transfusion dependent for life. Regular transfusions lead to accumulation of iron, which gets deposited in many organ systems, including liver, heart, pancreas, and endocrine organs, resulting in their dysfunction. To counteract, patients with thalassemia are prescribed iron chelator medications lifelong. Allogenic hematopoietic stem cell transplantation is the only available cure for beta thalassemia at present. However, it is routinely recommended only to patients who are HLA matched sibling donors, who have HLA matched sibling donors due to complications related to this procedure. Consequently, stem cell transplantation is offered to mere 10% of patients with beta thalassemia. Therefore, a vast majority of patients with beta thalassemia, those who live in developing countries like Sri Lanka in particular, are managed medically with blood transfusions and iron chelation for life. Most of the recent interest in the field of beta thalassemia has been on the discovery of curative therapies. Several pathways, including inhibition of mediators of ineffective erythropoiesis, upregulation of fetal hemoglobin by hydroxyurea, transfer of normal beta globin gene using gene therapy, and improving globin gene imbalance by genome editing are being tested at various stages of preclinical studies and clinical trials. Notably, several dozens of patients with beta thalassemia have already been cured by gene therapy in multiple trials. With this background, it is indeed reasonable for us to postulate that a cure for all patients with beta thalassemia will be available in the near future. However, poor medical management during the early years of life could lead to multiple complications related to chronic anemia and iron overload that would render patients unsuitable for these emerging therapies. Therefore, all clinicians caring for patients with beta thalassemia have a duty to optimize available supportive treatment to enable these patients to live a near normal life until a permanent cure is available, and to be free of serious complications that would exclude them from such therapy. The current situation in Sri Lanka. Although the medical management of beta thalassemia have improved considerably during the past 10 to 15 years, many patients in Sri Lanka still do not survive beyond the 4th decade. This is in contrast to higher life expectancies, usually up to the 6th decade, among patients with beta thalassemia managed medically in the developed world. Many factors could contribute to this disparity, which are understudied in Sri Lanka. One important factor can be related to the adequacy of blood transfusions, especially in the subset of patients with HBE beta thalassemia. The medical management and transfusion therapy for beta thalassemia are governed by the guidelines published by the Thalassemia International Federation in 2014. These guidelines are unambiguous and comprehensive and provide clear recommendations for the management of patients with beta thalassemia major. However, these, nor any other guideline available, provide sufficient guidance on transfusion therapy for patients with HBE beta thalassemia. Therefore, it is important to assess the adequacy of blood transfusion and clinical behavior of patients with beta thalassemia to provide scientific evidence to develop uniform guidelines to guide management of HBE beta thalassemia. Another important aspect that has not received adequate attention during recent times is iron overload and related complications. Despite the improvements in chelation with oral medication, most of the premature deaths in Sri Lanka are still due to iron overload. Hence, it is timely that we revisit the guidance on the assessment and management of iron overload of patients with beta thalassemia. Furthermore, beta thalassemia has transformed from a fatal disease with high mortality to a chronic disease which requires increasing attention to psychological health and quality of life. Several studies done in the past, when the medical care of thalassemia was relatively poor, showed that the patients with beta thalassemia experienced significantly poor quality of life. However, large-scale studies assessing the same after improvement in medical care are sparse. Therefore, in this oration, I aim to provide answers to these outstanding questions through a series of research studies conducted in Sri Lanka. Firstly, I aim to present a comprehensive analysis of the adequacy of blood transfusion in patients with beta thalassemia major and HBE beta thalassemia. Secondly, I intend to evaluate the body iron status and trends of iron overload among these patients. Thirdly, I will describe the quality of life among pediatric patients with beta thalassemia, again emphasizing the differences between beta thalassemia major and HBE beta thalassemia. Finally, I aim to determine the prevalence of psychological symptoms among patients with beta thalassemia to determine the factors associated with psychological health. We performed a series of multi-centered research studies from 2017 to 2019 in the three largest thalassemia centers situated in Kurunegala, Anuradhapura and Ragama teaching hospitals that care for over 2/3 of patients with thalassemia in Sri Lanka. These studies were confined to the pediatric age group. All regularly transfused patients with beta thalassemia who were aged between 2 to 18 years and attending thalassemia centers of above-mentioned hospitals were included. Regular transfusions was defined as receiving transfusions more frequently than 6 weekly. Patients with non-transfusion dependent thalassemia and thalassemia intermedia were not included in these studies. A total of 328 patients from 3 units were studied, of which 47% were males. 58% were from Kurunegala Thalassemia Center, 29 and 13% respectively were from Anuradhapura and Ragama Thalassemia Centers. 83% of patients had beta thalassemia major, whereas 16% had HBE beta thalassemia. Blood transfusion therapy. The Thalassemia International Federation guideline recommends maintaining a pre-transfusion hemoglobin level above between 9 to 10.5 grams per deciliter in all patients with transfusion-dependent beta thalassemia. By transfusing leukodepleted packed red blood cells 2 to 5 weekly. Aims of transfusion are to correct anemia and its complications, suppress bone marrow activity and extramedullary erythropoiesis, promote normal growth and normal physical activity. All patients in our study in all 3 centers received regular blood transfusions at 2 to 5 weekly intervals. The average pre-transfusion hemoglobin level over a 6 months period ranged between 4.6 to 11.7 with a mean of 8.3 grams per deciliter. Only 39% of patients maintained average pre-transfusion hemoglobin level above 9 grams per deciliter, suggesting inadequate transfusions in a majority. The presence of organomegaly is another indicator of extramedullary erythropoiesis and inadequate transfusions. Among all patients in the study, 32% had hepatomegaly, 34% had splenomegaly, and 2% were splenectomized. Then we evaluated the differences in the adequacy of transfusions between beta thalassemia major and HBE beta thalassemia. This analysis showed that the pre-transfusion hemoglobin level in patients with HBE beta thalassemia was significantly lower than that of beta thalassemia major. Only 4% of patients with HBE beta thalassemia had average pre-transfusion hemoglobin level above 9 grams per deciliter compared to 47% of patients with beta thalassemia major. Similarly, a significantly higher proportion of patients with HBE beta thalassemia had hepatomegaly and splenomegaly. These results suggest that the patients with HBE beta thalassemia in Sri Lanka were maintaining suboptimal hemoglobin levels and were in states of chronic anemia compared to patients with beta thalassemia major. Next, we examine the annual transfusion volumes received by these patients. Although the median annual transfusion volume of patients with HBE beta thalassemia was lower than that of beta thalassemia major, a large proportion of patients with HBE beta thalassemia were receiving high transfusion volumes. Notably, there was no significant difference in the proportion of patients receiving transfusion volumes over 200 milliliters per kg per year in HBE beta thalassemia and beta thalassemia major subgroups. These findings suggest that though the patients with HBE beta thalassemia were in states of chronic anemia, they were receiving large transfusion volumes, almost similar to that of patients with beta thalassemia major. This irony of suboptimal hemoglobin despite high transfusion volumes is most probably due to lack of consensus on the optimal pre-transfusion hemoglobin levels in patients with HBE beta thalassemia. Unlike beta thalassemia major, the clinical severity of HBE beta thalassemia is extremely variable. Depending on the amount of HBE synthesized, the severity varies from a minor disease which does not require transfusions through a milder non-transfusion dependent thalassemia requiring occasional transfusions to severe transfusion dependent thalassemia that requires regular transfusions. As clinicians, it is our duty to identify the category to which each patient belongs to and manage appropriately. If a patient requires only occasional transfusions, he or she can be allowed to have low baseline hemoglobin as low as 6 to 7 grams per deciliter, provided the individual is asymptomatic, have normal growth, and does not have rapid enlargement of the spleen. However, if a patient with hemoglobin E beta thalassemia requires regular transfusions more frequently than 6 weekly, he or she should be best managed similar to beta thalassemia major by transfusing regularly to maintain pre-transfusion hemoglobin levels between 9 to 10.5 grams per deciliter, which is not happening at the moment in Sri Lanka. Another important aspect that we examined was transfusion-transmitted infections, which pose great risk to the patients with beta thalassemia. In our cohort, 20% of patients were diagnosed with hepatitis C infection. This high figure raises serious concerns over the safety of blood products and reflects the limitations of effective screening of blood donors. Hepatitis C infection is also known to increase the annual transfusion requirements of patients with thalassemia. This was confirmed by our results, which showed that the median annual transfusion volume among patients with hepatitis C was significantly higher compared to others. Additionally, our study revealed that the pre-transfusion hemoglobin levels of patients with splenomegaly and hepatomegaly were significantly lower compared to patients without organomegaly. Furthermore, Median annual transfusion volumes were significantly higher in patients who are underweight. All these results are published in our recent paper in the journal Pediatric Blood and Cancer. Iron overload and related complications. Iron overload is an inevitable complication of beta thalassemia. This is due to two main reasons. Firstly, the patients with beta thalassemia have inappropriate suppression of hepcidin, which in turn promotes intestinal iron absorption, despite having high body iron stores. Secondly, each packet of red blood cells infuses 200 milligrams of iron into the body, bypassing the intestinal regulation of iron absorption. This excess iron gets deposited in body organs including heart, liver and endocrine organs, leading to organ dysfunction and failure. Thalassemia International Federation guideline recommends commencing iron chelation, commencing screening for iron overload when patient receives 10 to 12 blood transfusions. Serum ferritin is the most widely used indicator of iron overload, which should be maintained below 1000 nanograms per milliliter. Additionally, several invasive MRI-based techniques that reliably measures organ-specific iron load in the heart and liver are available. However, these methods are expensive and not widely available in Sri Lanka at present. The mean serum ferritin of the study population was 1923. Only 32% of our patients had serum ferritin in the desirable range. Worryingly, 20% of patients were having very high serum ferritin, about 2500. This was despite receiving iron chelator medications, oral deferoxamine, subcutaneous desferrioxamine, or combination of both, which are given free of charge by the government. We observed significant differences in the serum ferritin level between beta thalassemia major and HBE beta thalassemia. Among patients with HBE beta thalassemia, 48% had optimal serum ferritin, while only 28% of patients with beta thalassemia major had serum ferritin less than 1000. Then we looked at the prevalence of iron-related complications in our cohort. Short stature was the commonest complication and was present in 43% of our patients. The next common was delayed puberty, which was seen in 26% of adolescents. Prevalence of cardiac dysfunction was extremely low, while none of the patients had evidence of chronic liver disease. However, we did not assess the myocardial or liver iron content by MRI-based techniques. With regard to other endocrine complications, 3.4% had hypothyroidism and 1.5% had diabetes. The relatively low prevalence of endocrine complications, despite having high serum ferritin in a majority, is most likely because our results were confined to the pediatric age group. Though the serum ferritin levels were different, we did not observe a significant difference in the prevalence of iron-related complications between patients with beta thalassemia major and hemoglobin E beta thalassemia. Next, we performed a detailed analysis of trends of serum ferritin in a subset of pediatric patients with beta thalassemia. The trend of mean serum ferritin plotted longitudinally at yearly intervals showed a rapid rise in serum ferritin during the first 5 years of life, before reaching a plateau. Importantly, in most patients, serum ferritin was greater than 1000 even before they were 2 years old. These findings suggest that the body iron control is suboptimal in most patients, especially during the first 5 years of life, emphasizing the need for intensifying iron chelation during first years of life. Importantly, we believe that the assessment of iron overload and iron chelation should not be delayed until the child receives the 10th transfusion as stipulated by the Thalassemia International Federation, but should be performed much earlier, preferably after 5th to 6th blood transfusion. Also, the threshold for commencement of iron chelation should be lowered for patients with transfusion-dependent beta thalassemia to avoid a rapid rise in serum ferritin during first few years of life. Quality of life. The outlook of beta thalassemia has remarkably transformed during the last decade from a life-threatening fatal disease to a chronic disease with disability. Consequently, uplifting quality of life has become important in the management of beta thalassemia more than ever. Therefore, in our next study, we evaluated the quality of life in patients with transfusion-dependent beta thalassemia. We used previously validated pediatric quality of life inventory 4.0 to determine the quality of life. This tool assesses quality of life in 4 dimensions: physical, emotional, social, and school functioning. The score for each category range from 0 to 100, with higher scores representing better quality of life. For comparison, we recruited a randomly selected group of children without chronic diseases from the same hospitals as for this study as controls. A total of 271 regularly transfused patients with beta thalassemia and 254 non-thalassemia controls were recruited. Age and sex distributions of patients and controls were similar. Comparison of quality of life between 2 groups revealed significantly lower mean quality of life scores in patients with beta thalassemia compared to controls in all dimensions. This was not surprising considering the chronic nature of the disease and the amount of physical and psychological stress that these patients have to undergo. Next, we compared the quality of life among patients with beta thalassemia major and HBE beta thalassemia. It revealed significantly lower quality of life scores in emotional functioning and social functioning in patients with HBE beta thalassemia compared to beta thalassemia major. This is rather unexpected given the fact that HBE beta thalassemia is considered as a relatively minor disease. However, as discussed earlier, regularly transfused patients with HBE beta thalassemia in Sri Lanka were in states of chronic anemia despite transfusions. We believe this has most likely contributed to lower quality of life in patients with HBE beta thalassemia. Then we attempted to identify the associations and determinants of quality of life among beta thalassemia patients. In this analysis, we found that patients who underwent splenectomy and were short or underweight had significantly lower quality of life scores. Similarly, longer hospital stays and lower paternal education and occupation levels were significantly associated with poor quality of life. These results are published in our next paper in journal Health and Quality of Life Outcomes. Psychological health. In the final research study presented in this oration, we assessed the prevalence of psychological symptoms among patients with beta thalassemia. We used previously validated strengths and difficulties questionnaire that measures psychological health among 5 scales, psychological symptoms among 5 scales. That is, emotional symptoms, conduct symptoms, hyperactivity symptoms, peer relationship problems, and prosocial behaviors. Of the 288 patients studied, abnormal emotional conduct and hyperactivity symptom scores were reported by 18%, 17%, and 9% of children with transfusion-dependent beta thalassemia. 14% had abnormal peer relationship scores. Patients with HBE beta thalassemia reported significantly higher prevalence of abnormal conduct symptom scores compared to patients with beta thalassemia major. Next, we examine the clinical and socio-demographic factors associated with abnormal psychological symptom scores using logistic regression. A significantly higher proportion of children with suboptimal pre-transfusion hemoglobin levels and had abnormal conduct and peer relationship scores. The presence of hypothyroidism and undernutrition was significantly associated with abnormal conduct scores, while short stature was associated with abnormal emotional and hyperactivity symptom scores. Finally, we examine the relationship between maternal depression and psychological symptoms among patients with transfusion-dependent beta thalassemia. Maternal depression in this study was assessed using the previously validated Center for Epidemiological Studies depression scale. This analysis revealed that high depression symptom scores in mothers were significantly associated with abnormal psychological symptom scores of children with beta thalassemia. These results are published in our paper in PLOS ONE. Conclusions and recommendations. Ladies and gentlemen, in this oration, I presented the results of several studies done in one of the largest cohorts of pediatric patients in beta thalassemia in Sri Lanka, maybe in the world. Here, we attempted to resolve several outstanding issues related to transfusion therapy, iron overload, quality of life, and psychological health in these patients. Based on the results which were just presented, I make the following conclusions and recommendations regarding medical management of patients with transfusion-dependent beta thalassemia. 1. Despite receiving high transfusion volumes, most patients with hemoglobin E beta thalassemia were in states of chronic anemia. This is likely to be related to non-uniform practices of individual units due to lack of specific guidelines. Therefore, until specific guidelines for HBE beta thalassemia are developed, all patients with HBE beta thalassemia who requires regular transfusions more frequently than 6 weekly should be managed similar to beta thalassemia major, with transfusions to maintain pre-transfusion hemoglobin between 9 to 10.5 grams per deciliter. However, I must re-emphasize that this should not be confused with a large group of patients with hemoglobin E beta thalassemia who requires no or occasional transfusions, the mild group of hemoglobin E beta thalassemia. These patients should continue to be managed as non-transfusion dependent beta thalassemia without transfusions, and the requirement for transfusion should be decided individually without being purely based on hemoglobin levels. 2. Over 1/5 of children with beta thalassemia were infected with hepatitis C. This raises huge concerns on the safety of blood products and the moral responsibility of caring physicians who swear Hippocratic oath, above all, do no harm. Therefore, ensuring the safety of transfused blood is of paramount importance. 3. Trends of serum ferritin revealed a rapid rise during the first 5 years of life, emphasizing the need for intense iron chelation during first few years of life. Assessment and management of iron overload should not be delayed, but be performed earlier than previously recommended, preferably after 5 to 6 blood transfusions. Similarly, the threshold for commencement of iron chelation should be lowered to avoid a rapid rise in serum ferritin during the first few years of life. 4. assessment of iron-related complications are also suboptimal at present. As a result, patients may be picked at very late stages of organ dysfunction, especially in the heart and liver. Although organ-specific iron load can be assessed using MRI-based techniques locally, the accessibility to these facilities are limited. Therefore, these facilities should be decentralized to areas where it is required most. 5. Despite improved management, patients with beta thalassemia still experience a poor quality of life and have abnormal psychological symptom scores. This is more pronounced in the subset of patients with HBE beta thalassemia. It is timely, as caring physicians, we direct our emphasis to take appropriate steps to improve the standards of living and quality of life of these patients. 6. Although not elaborated in this oration, there are many aspects that we can improve at the national level. Thanks to the effort by individual researchers, we already know that there are approximately 1,800 patients with beta thalassemia in Sri Lanka. However, we still do not have a national thalassemia registry. Despite lengthy discussions over several decades and several initial attempts, we have not been able to produce a registry. Therefore, I believe that the patient database of the study and the island-wide survey conducted previously should be transformed into a patient registry with the support of all healthcare professionals taking care of patients with beta thalassemia. In conclusion, ladies and gentlemen, in this oration, I have highlighted several important issues that hinders improvement in morbidity and mortality of patients with beta thalassemia in Sri Lanka. I sincerely hope the recommendations made today will improve the standards of care and quality of life of patients with beta thalassemia in Sri Lanka. This will enable them to live a near normal life until a permanent cure accessible to all patients with beta thalassemia becomes available, hopefully in the very near future. The work presented today would not have been possible without the support of many in our research team. My sincere thanks goes to a bunch of very efficient research assistants, namely Drs. Hashan Pathiraja, Ravindu Piris, and Nethmi Wickramasinghe, who were involved in the collection of data and maintaining patient databases. My departmental colleague, Tharindi Suryaperima, carried out the study on iron overload, while Dr. Miyuru Chandradasa was instrumental in designing the study on psychological morbidity. Thank you very much for both of you. None of this work would have been possible without the continued support from Dr. Dayananda Bandara and Dr. Udaya De Silva, consultants in charge of thalassemia centers of Kurunegala and Anuradhapura, and the staff in all 3 thalassemia centers. Also, I sincerely acknowledge the support, guidance, and the scientific input from Professor Anuja Premawardana throughout these studies and beyond. Finally, my heartfelt gratitude goes to my wife Chamila and kids Kalya and Kaushala for being understanding and encouraging at all times. Thank you.
Thank you, sir, for that very interesting and informative oration. And we congratulate you on your research and achievements and wish you the very best in all your future endeavors. So, ladies and gentlemen, as we conclude the academic program of this evening, we have a very entertaining musical interlude lined up for you, featuring 2 amazing vocalists. First up, we have Mr. Jagat Wickramasinghe, who is one of the most celebrated singers in Sri Lanka, who will be performing a classical Sinhala song, which is one of his original Sinhala songs, Obat Mamat Hindina Me Lewa Tula.
ඔබත් මමත් හිඳිනා මේ ලොව තුල කඳුල සුසුම කුමකටදෝ ඔබත් මමත් අප දෙදෙනෙකු ලෙස නොව එකෙකු ලෙසින් සිතමු හිතින් උදාවන ලෝකය සැමටම සුවදායක කරමු හිතින් උදාවන ලෝකය සැමටම සුවදායක කරමු අවි ගැටෙනා බිම් තලය පුරා යුදයේ ගිනි දැල් පැතිරෙන්නේ දුක් විලාපයයි මිනිසුන්නේ යුද වැදී කුමට මේ එකම පොළොව මත එකම ලෙයින් අප සැදුනේ එකම සුසුම් ලය රැඳුනේ ඔබත් මමත් හිඳිනා මේ ලොව තුල කඳුල සුසුම කුමකටදෝ ඔබත් මමත් අප දෙදෙනෙකු ලෙස නොව එකෙකු ලෙසින් සිතමු හෙටින් උදාවන ලෝකය සැමටම සුවදායක කරමු හෙටින් උදාවන ලෝකය සැමටම සුවදායක කරමු රකිමු මිනිස්කම් බේද නොවී කුලගොත් පුස්මිටිකම් දුරලා සතුරු සිතුම් අත්හැරලා කුසගින්න අවිදරා දැවේ ලපටි සිත් කඳුළු පිසිමු දරුවන්නේ සතුට බෙදමු මිහි මඬලේ ඔබත් මමත් හිඳිනා මේ ලොව තුල කඳුල සුසුම කුමකටදෝ ඔබත් මමත් අප දෙදෙනෙකු ලෙස නොව එකෙකු ලෙසින් සිතමු හිටින් උදාවන ලෝකය සැමටම සුවදායක කරමු හිටින් උදාවන ලෝකය සැමටම සුවදායක කරමු හෙටින් උදාවන ලෝකය සැමටම සුවදායක කරමු ස්තුතියි මා ස්තුතිවන්ත වෙනවා මට මේ වැදගත් උත්සවය සඳහා ආරාධනා කළ මහාචාර්ය ඉන්දික කරුණාතිලක මහත්මයාටත් ඒ වගේම මම හිතනවා අද කාලීනව වැදගත් වෙන මාතෘකාවක් සුවදායක බව ඒ නිසා ඔබ හැම දිනෙකම ජීවකයින් මානව සංහතිය ජීවත් කරන විශේෂිත වටිනා පුද්ගලයන් මම හිතනවා ඔබේ අරමුණත් එයයි කලාකරුවන් විදිහට අපේ අරමුණත් එයයි එය මම හිතනවා මේ අවස්ථාවට උචිතයි කියලා හැමදෙනාටම ස්තුතියි
Thank you. What a heartwarming performance indeed. So, ladies and gentlemen, that was Mr. Jagat Vikramasinghe with Obat Mamat Hindiname Lovatula. And next up, we have a very talented doctor, Dr. Nilanka Anjali Vikramasinghe, who is actually a lecturer at the Department of Physiology at the Faculty of Medicine, University of Colombo. She'll be performing 2 songs. First up, we have Sina Pipana Me Vasante, which has been originally sung by Lakshman Vijayasekara and Samita Mudun Kotua. So over to you, Nilanka.
ගම්මැදින් හමනා පවන සිහිලැල් ගම්දොරින් පිට මං නොවේවා නැවුම් සුඹ යෞවනයේ හසර සිනා පිපෙනා මේ වසන්තය නෙලා දෝතින් මලක්සේ මගේ ලොව වෙත ඔබයි ගෙන ආවේ සිනාසේ ඔබයි ගෙන ආවේ වසන්තය මලක්සේ නිසාල සිතුවිලි සසල පුරුලිය අතර තනි වෙමි ඔබ නිසා සතුටින් ආස සමුදුර සමග සැනසෙමි තැනක සඟරමි හද කොනේ සුසුමින් සිනා පිපෙනා මේ වසන්තය නෙලා දෝතින් මලක්සේ මගේ ලොව වෙත ඔබයි ගෙන ආවේ සිනාසේ ඔබයි ගෙන ආවේ වසන්තය
So the next song sung by Nilanka will be the theme song of the movie Love Story, originally sung by Andy Williams.
To tell the story of how great love can be, the sweet love story that is older than the sea, the simple truth about the love he brings to me. Where do I start? With his first love, he gave meaning to this empty world of mine. There'll never be another love, another time. He came into my life and made the living fine. He fills my heart. He fills my heart with every special things, with angel songs, with wild imaginings. He fills my soul with so much love that anywhere I go, I'm never lonely with him alone. Who could be lonely? I reach for his hand, it's always there. How long does it last? Can love be measured by the I have no answers now, but this much I can say. I know I'll need him till the stars all burn away, and he'll be there. I want is at last kept love official by the others in our team. I have no answers now, but this much I can say. I know I'll need him till the stars all burn away, and he'll be
Thank you. And I want to thank my professor, Professor Indika Karunatilaka, for giving me this opportunity to sing today. Thank you very much, sir.
Thank you, Nilanka. A breathtaking performance indeed. So, ladies and gentlemen, with that delightful performance by Dr. Nilanka Anjali Wickramasinghe, we have come to the end of this inauguration ceremony of the 133rd Anniversary International Medical Congress of the Sri Lanka Medical Association. The scientific sessions will commence from tomorrow, and it will be broadcast live from the SLMA. And on behalf of the Sri Lanka Medical Association, I would like to thank all of you who have joined us today at this landmark event. So to conclude the proceedings, the ceremonial procession will exit this venue accompanying our guest of honor and the orator, and I kindly request the audience to stand as the ceremonial procession leaves the hall. So thank you, ladies and gentlemen. Do have a pleasant evening. The refreshments will be served downstairs. You may collect your packed refreshments. Thank you.